welcome. Firstly, I'd like to introduce myself. My name is Brandon Reed. I am the public historian here at the International African American Museum. I'd like to welcome you all to the IAAM and thank you all for joining us for what has been and what will be and will continue to be a remarkable afternoon. We look forward to connecting with each of you and we'll begin our program shortly. The session is being recorded, so I do want to make sure I point that out. This session is being recorded for sharing with a broader audience at a later date. I am pleased to welcome you all to, again, IAAM. We just opened earlier this June, but we've already had so many amazing partnerships, collaborations, and this has been one of the great ones as well that we'll continue to explore and delve more deeply into this conversation and others. But the name of our session today is Small Miracles, a promise towards a future of health and wellness. We're hosting it in partnership with our great friends at the BrightFocus Foundation, represented here today by Stacy Haller and Nancy Lynn, and many members of their board of directors. I'd like to turn things over to Stacy to share a few brief remarks.
Thank you, Brandon. It's really been wonderful to be here at the museum and to have this opportunity to talk more about an important issue around health equity and how these medical milestones will touch and reach all of us around the globe. So thank you, and we're looking forward to a lively discussion.
Thank you so much, Stacy. I would like to introduce you to Dr. Tonya M, founding president and CEO of the International African American Museum. Dr. Matthews is a thought leader in institutionalized equity and inclusion frameworks, social entrepreneurship, and the intersectionality of formal and informal education. Her background as a poet, engineer, and in biomedicine has made her a highly sought after visioning partner on boards and community building projects, as well as frequent public speaker and presenter for communities across all ages and venues. We are fortunate to have Dr. Matthews as the moderator of this panel, and I'd like to welcome her up to get things started for us.
Thank you very much to Brandon Reed, the public historian here at the International African American Museum. Yes, you all may applaud. He has already forgotten more than many of us will know, and he has years and years of more information to share and compel here at his journey at the International African American Museum. So we are very excited to be hosting this panel, this conversation this evening. And one might ask, why is a history museum stepping into a space and telling stories about science? I specifically came out because you said there'd be no math. I will keep the percentages to a minimum, but I will say that this is also part of the story, because one of the things we want to normalize is having these kinds of conversations in our communities. We always talk about we always need to be partners in our own health and in our own healthcare. That requires us to have a level of knowledge, a level of curiosity, but also a level of trust, a level of engagement in the space, a level of honesty and a level of transparency that not every community has been able to benefit from as they're having these conversations. And so we want to talk about that. We want to talk about the road to the cure. We want to talk about getting African Americans involved. We want to talk about getting rural communities involved. We want to talk about getting everyone involved. And so we've titled this conversation Small Miracles so that it seems a little less scary, but anyone that knows anything about Sunday knows there's nothing small about any miracle. They're always a little scary. But we're hoping that still works. So what we're going to do is we're going to kick off and we're going to introduce each one of our four panelists in context. You've already gotten the opportunity to meet the president and CEO of BrightFocus, Ms. Stacy Haller. So for our next introduction, we are going to be introducing to you and reintroducing to many of you, someone that you've already seen or known, or perhaps you've benefited from the work. But rather than read the bio, I think it might be easier to give you some visual, because our first panelist was the 2023 Woman of the Year for News Channel 2. So of course we have some footage we can share.
After months of searching, we have finally determined who the Lowcountry's most remarkable woman is. Every year we hold a contest here at Channel 2 where we look for women who inspire, lead, and forge the way for other women, day in and day out. And we received hundreds of nominations. We narrowed that down to 4 finalists. And now we are introducing the Lowcountry's Remarkable Woman of the Year. Congratulations, Dr. Marvella Ford. We will be speaking to her live here on the set in just a moment, but first, News 2's Carolyn Murray had a chance to catch up with her. Here is Dr. Ford's story.
I think 2 days in a row that I didn't have to do anything.
Dr. Marvella Ford has been on a healthcare path for as long as she can remember.
I grew up in Plattsburgh, New York. It was a very, mostly a population made up of mainly white people. There were some Native American, American Indian people, and a few Asian American people. Most of my friends were white, obviously, because that's who lived there.
But her curiosity was piqued by who was missing in her life.
And they all had grandparents. Most of them had all 4 grandparents. And by the time I was born, all 4 of my grandparents had already passed away. When I looked at them and I looked at myself, I realized there's a racial difference. I remember as a child thinking, I'm going to find out and I'm going to help people so that when their kids grow up, they will have their grandparents for a longer period of time.
Dr. Ford said her parents were brilliant, but not academic scholars. But they made sure she and her brothers would be.
And I remember my father telling my older brother and myself, your job is to go to school and get good grades.
And she did, earning a scholarship and high marks at a world-class school, Cornell University, and then a doctorate at the University of Michigan, Ann Arbor. Years of training and research eventually brought her here to the Hollings Cancer Center and the Medical University of South Carolina, where she not only teaches medical students, but educates the public and puts access to care in neighborhoods, especially in rural communities.
We are very pleased that we have a brand new mobile health unit. I don't know if people know that the mobile health unit now that Hollings Cancer Center uses for mammography is brand new.
And that is not the only mobile unit Dr. Ford got rolling. She says the HPV van will save lives because it offers the cancer vaccine.
The van travels throughout the state. We work with school districts across the state to deliver the HPV vaccine.
Dr. Ford created a program that targets African American men. SCAMen helps men understand prostate cancer, treatment options, resources for support, and follow-up care.
In South Carolina, the prostate cancer death rate is 2.5 times higher for black men than for white men. That means that there's something that we can do. We can make a difference.
And she's making a difference in the lives of high school students, too. SC Cure, or SC Continuing Umbrella of Research Experience, has a record for directing minority high school students towards STEM education. From classrooms to clinical trials, Dr. Ford is at the forefront of encouraging black and brown people to be involved.
If people of color and other people across the community, rural residents, if we are not involved in these trials, then at the end of the day, it won't be clear how well those treatments will work for us.
She goes on to explain that because her mother died of complications of diabetes and her father heart disease, she was vigilant about her own health screenings. But in 2008, the doctor became the patient. She received a diagnosis she did not expect: breast cancer.
The cancer was detected at stage 0, which was really a blessing. I received great care. I feel very blessed to work in an institution where there are so many specialists. After growing up in a very small town where it was difficult to access specialists, it comes back full circle. So it's kind of maybe something that I didn't have in my life, the grandparents. Now other people will be able to enjoy their grandparents, their children, their spouses for a longer period of time. And it makes everything worthwhile. It makes all the late nights, the early mornings, the weekend work, it makes it all worthwhile.
There is the story. Dr. Marvella Ford is our remarkable woman this year. We're so excited, Dr. Ford. Congratulations.
Thank you so much. I'm
So happy.
We're so happy to have you here live on set now, just to get to chat to you a little bit. I mean, we know that you do great work as a medical researcher, as a patient advocate at MUSC. We're so lucky to have you here in the Lowcountry, but I'm curious, Dr. Ford, how did you feel when you first found out you were nominated to be a remarkable woman?
Oh my goodness, I was amazed. I just couldn't believe it. Ms. Ellen Gomez from the Hollings Cancer Center nominated me. I was just thrilled beyond belief just to have been nominated. It's such an honor.
Well, it's obviously a great program. We love being part of this at News 2 every year. And Dr. Ford, you know, your work you do is all encompassing, especially with what you're doing to again advocate for healthcare. So I want you to talk a little bit about these mobile healthcare vans that are somewhat new. And I mean, it's everything from HPV vaccines to mammograms to all kinds of healthcare services on the road. Tell me about this program.
Thank you so much. Well, as you know, we live in a very rural state. And a lot of people have transportation problems. They may have issues where they may not be able to get to a healthcare provider. So we take these services to the people where they live. And we work with them. So when we go out with our mobile health unit for breast and cervical cancer screening, from the time a woman steps foot on that mobile unit, she becomes a patient of the MUSC Hollings Cancer Center. And we help to navigate and guide her through the process of screening and diagnostic workup, and if necessary, treatment. And the same with our human papillomavirus HPV vaccination van. We are so thrilled to have this new van that's funded by Healthy Me, Healthy SC. This vaccine prevents 6 different types of cancer.
Wow. So that's really some groundbreaking work you're doing. What is the education process of this like? What's the feedback been being out in some of these rural communities that might not even know about that vaccine?
You know, the feedback has been phenomenal. People are so excited to learn that there's a vaccine that prevents 6 different types of cancer. And a lot of parents immediately want to get their children vaccinated because most parents want to do something to help ensure that their children have longer, healthier lives. And getting their kids vaccinated with the HPV vaccine is one way to ensure that at least they won't have to worry about these 6 different types of cancer.
Amazing. And Dr. Ford, you know, looking at your bio and some of the things you've accomplished, you went to Cornell, you went to an Ivy League school, you're highly educated, you're from New York originally, but made your way down to the Lowcountry, and we're blessed to have your talents here in our area. But along the way, do you feel like you had other remarkable women that sort of showed you what you could become?
Absolutely. In my entire life, I've had the blessing of being surrounded by remarkable women, from my mother, who was a brilliant woman but didn't have the opportunities for educational attainment that I have, all the way to my aunts. I didn't have my grandparents because they had all passed away before me, but I had my high school guidance counselor is actually the route that led me to Cornell University. I've had wonderful faculty mentors along the way who really believed in me and showed me a vision for a future that I didn't even know could exist.
That's beautiful. And Dr. Ford, you know, now that you are a remarkable woman, do you feel like in your role, especially at MUSC, that you're around other young women and you're able to sort of help advocate for them and push them along their path and maybe even inspire them?
Absolutely. We have training programs for undergraduate students from historically Black colleges and universities. And this summer, we're working with 4 high schools, Burke, St. John's, the Charleston Charter School for Math and Science, and North Charleston High School. And we'll have 20 high school students at our Cancer Center this summer, supported by the Cancer Center, getting training in cancer research so that we can keep going with this next generation.
That's wonderful. And speaking of next steps, you know, if you're not familiar with Remarkable Woman, our parent company, Nexstar, which owns our station as well as lots of local news stations across the country, each of these stations nominates a remarkable woman, and then they all travel this year to Los Angeles to meet each other and participate in a live show. So Dr. Ford, tell me how you feel about this trip that's coming up.
I am just so delighted. I cannot believe I was selected. I mean, I was in the company of such amazing women, and I'm just very humbled to have even been in the same category as the other nominees. So I wish them success. I'm so happy for all the great work that they are doing, because really we're all in this together, and together we can make a difference.
Well, Dr. Ford, we are so excited to have you represent us, represent News 2 in Charleston at this upcoming event, and you have to fill us in on how it goes afterwards.
Thank you so much.
Big congratulations. Thank you for being here. You are a remarkable woman.
Thank you.
Our first panelist for this evening. Now, Dr. Ford, one of the things that I noted in your in your story is that you have played a lot of roles. You've been the granddaughter, you've been the daughter, you've been the doctor, you've been the patient. You could have stopped there, but you've also been the advocate, the connector, the spokesperson. So in all of those various roles that you've had in the work that you do, is there some guiding lesson that has taken you through all of those experiences or that have brought you in that space?
Thank you so much. It's truly an honor to be here in this company, and thank you. Yes, I think the lesson is that we are united, and healthcare is a right, not a privilege, and that all of us have an obligation to ensure that the rest of us, not just ourselves, have the same level of access to care that we have. It's not good enough for us to be able to see a doctor or a specialist if our neighbor can't, because we live in one society. So what affects our neighbor affects us. The health of our neighbor affects our health. It affects our economy. It affects who's teaching our children. It affects who is providing the care. It affects who is able to work. So I think there are some lessons that we learned during the pandemic, which is that we are interconnected and interrelated, and our society is a fabric that's interwoven with all of us. And what happens to one group impacts other groups. So when we talk about improving health equity, we're really talking about improving the quality of care for everyone. Study after study has shown that when we improve the quality metrics and reduce disparities, the health of the entire population increases and the metrics of everyone improve. We control blood pressure better for everyone. We are able to get people in for screenings across the board so that we are able to detect cancers at earlier stages or detect other diseases at earlier stages when intervention is still possible. So what affects the community that is the most underserved? When we develop interventions to improve health outcomes in that group, we are improving health outcomes for the entire population.
Thank you for that. I hear a lot of mm-hms and ums. Now, of course, Dr. Ford's story included engagement across many, many levels, across many conditions and outcomes and diseases that we talked about. Let's zero down just a little bit. We're going to zero in and we're going to focus a bit on Alzheimer's. Our next guest is Dr. Deborah Tan. In addition to being Dr. Deborah Tan, she is the CEO of an organization called Reminiscent and has committed her life's work to advocacy for Alzheimer's and related dementia. Now, of course, you know, someone, when you're very, very creative, scientific background or not, and you name your organization, it tends to be for a reason. And of course, Reminiscent is reflective of the word reminisce. Individuals living with dementia often reminisce or find themselves reminiscent of the past. It's a way of sort of being in that space. And so even the very name of the organization honors those to whom she has committed her life to serve. Now, BrightFocus Foundation became engaged with Dr. Tan through a very interesting project down in Valdosta, Georgia. So, you know, we're going to expand the Lowcountry just a little bit. And we are going to share with you a short video that talks a little bit about the work that Dr. Tan has been doing.
Valdosta, Georgia, home to over 55,000 people. Like many communities across America, disparities in healthcare have plagued this town, where until recently, brain health and dementia awareness have not been a major focus. What is Alzheimer's?
Well, I couldn't tell you exactly myself. The education of it is not very clear in our areas.
Alzheimer's is a disease, a problem that I can't explain.
Oh, Lord. Well, Alzheimer's, so is a delay, a disorder, a disease that is within the brain.
It has to do with brain health, and I apologize, I don't know exactly what is Alzheimer's.
I'm not sure. I'm studying up on it.
What is Alzheimer's? It's a form of dementia. It affects the person thinking, what they can remember or can't remember, and it can be pretty devastating for any person and family.
As a layman, I would say that it's a degenerative disease of the mind that progresses sometimes slow, sometimes fast, but always in a miserable way.
Mostly we think it's in older people. There's some young folks with Alzheimer's as well.
Even though we hear about it now, in terms of how long it's been a diagnosis or a familiar term in society, that's only been like maybe 30 or 40 years.
Where are we going? We're going to the park?
People of color, black and brown people, people that look like me, are at the top of the food chain with respect to dementia. Why is that so?
Education is a big problem here with dementia.
Education of mental issues or challenges are not something that we really readily get made aware of.
We know based on research that 1 in 4 doctors have very little training when it comes to dementia education. I would love to see better relationships with the medical profession so they can be trained in how to engage with someone living with dementia. I do believe, in my most humble opinion, that the cure is going to come out of a clinical trial.
We can get African Americans in clinical trials when we actually do targeted outreach to those groups instead of doing this blanket, hey, we told them, oh, it was on this website, but most times our people don't have access to those, or they don't have the social capital, or they're not connected to someone who wouldn't even know about a clinical trial.
I know clinical trials are important so we can have better health.
Basically, it's a test. Clinical trial, I guess you could say it as that.
Would you volunteer for a clinical trial?
Yes, depending on what it is.
I was asked to have someone come into our community to do presentations on clinical trials. But I said, let's hold off. Give me 6 to 12 more months, because I need to educate the community just a little bit more about the basics of dementia first. We can't jump from not understanding what dementia is all the way to clinical trial.
There's a second guess on whether or not we want to actually be a part of certain trials. There's a mistrust.
So much wisdom from the ground up there, and I'm always struck by that phrase. You can't jump from not knowing what dementia is straight into asking folks to participate in a clinical trial. So can you give us an update on what's going on and where we are sort of in that community, and what your vision is as this actually moves forward?
Oh, yes. Good afternoon. It's a pleasure to be before you on this afternoon. I bring you warm greetings from Valdosta, Georgia. We have really taken off in Valdosta in terms of education. Education is the essence of all the work that I do. And I am blessed in that I have over 30 years of educational experience. So it comes natural for me to be able to educate our community about dementia. So you must be wondering, so what are you doing? BrightFocus and I have teamed up, Reminiscent that is, and so we build awareness, if you will, around campaigns in our community, and we try to educate. Pardon me, we're not trying, we're actually doing it. We have boots on, not boots on the ground, but heels on the ground, because I'm working there. We use social media, of course, and platforms. We have educational workshops for sure. We're trying to build trust. And if you do a little bit of research, there's a difference between mistrust and distrust. And so we're trying to build relationships, because that's what it's all about. And if you think about it in our lives, relationships are quintessential to any and all that we do. So Valdosta and Reminiscent, and certainly BrightFocus, we have brain health screenings taking place in the community. We train and work with healthcare professionals because they can utilize instruments as well to do brain screening. We work with leadership because we know, at least I know you know, policy is important. So it's important to work with your local, your state, and certainly your national leaders because they influence policy. And so I like to think that I do that in a very instrumental way. I'm a very strong advocate of cultural competence services and support. Even when it comes down to brochures, I want sometimes the people to look a little bit like me, a little bit of hue, if you will. So we work hard with workforce development in our community, as well as building in our diversity efforts in the community. I'm a staunch advocate, and I'll say this last part, I'm a staunch advocate in making sure that the architect, the clinical trial, if you will, is brought to the people. See, I believe this. If the people can't get to you, bring it to the people. And I'll leave it right there for right now.
Thank you. Am I the only one that just feels like you just had a poem read for us? So now we're talking about education, and we've been talking about educating the community, right? Like building things and educating and having that conversation from the ground up. But Dr. Pan hinted at something as well, that sometimes you also have to educate from the top down. And so it's not just the folks in the community that need to be understanding what the challenges are and why this research is important, why engagement is important. Sometimes you have to go all the way to the top. And so recently, BrightFocus did do that. We got pretty close there and were able to hold a session on Capitol Hill. And speak to some of the folks there. And so just before we introduce our last speaker, who was the architect of that event, we're going to show a little video to show what we did when we were up in Capitol Hill.
When it comes to the clinical trials that are fundamentally essential to turning medical research into effective new treatments, Blacks and Hispanics, women, and many other under-resourced populations are systematically not represented.
Despite their higher rates of developing Alzheimer's, underrepresented groups are significantly less likely to be diagnosed with the condition. Lack of diagnoses means lack of treatment. But it also means, you guys, they are unlikely to enroll in an active clinical trial.
White patients still make up 92% of clinical trial participants. When our clinical trial participants are different and diverse, it motivates the questions that we ask. The questions that we ask and the research challenges that we take on in and of themselves also become more diverse, more creative, because we have a broader pool of people. That is how we get to innovation. We need the full breadth of genetic markers inside all of these trials that we're doing for things that come up as anomalies are actually roads to the cures and to the innovations and the path that we need. So this is why diversity within our clinical trials is actually about curing the broader population of all of these things that ail us, not just being in service to particular populations.
Let's be bold and resolve here and now to relegate clinical trial inequities into the medical history books. Let's be bold and commit to our underserved communities. Let's be bold for them, for ourselves, for our children and theirs.
Okay, clearly I was having a moment in that space. And as I mentioned, our last panelist was a big part of bringing all of that together. Ms. Nancy Lynn is the Senior Vice President of Strategic Partnerships for BrightFocus Foundation. And in that role, among many things, is the stewarding of mission-based partnerships that help to accelerate scientific advancement and generate greater public awareness of Alzheimer's, macular degeneration, and glaucoma, the big three for BrightFocus. Now, BrightFocus Foundation is committed to addressing health disparities through several of the programs, as you can see. And the title of that event was Diversity Starts in the Lab. So as we have doctors on this panel and we've gotten a chance to see some images of scientists actually working, we're talking about taking this from the roots all the way out to the trials, all the way out to the treatments. So the question I wanted to ask you, Nancy, because I remember when you were preparing us for that session, you said, don't worry, our goal is just to get people talking. We just want to get people talking. So my question to you is, why is the goal just to start off to get people talking, and who is it that we want to get talking?
Well, thank you, Doc T, as I know you're affectionately called, and thank you to the museum, to Brandon, Malika, Ileana, Kiana, and everyone who's helped organize this event. We're so excited to be here. We have to get people talking because this is something people just don't want to talk about. Two things. They don't want to talk about dementia. They don't want to talk about, it's terrifying. And you don't want to talk about diversity in those trials, especially, I have to say, in the academic communities. We're not an advocacy organization, we don't lobby on the Hill, but we felt it was really important to do a congressional briefing, to begin those conversations in the way that we do, really focused on on research and clinical trials. So the good news in terms of the government is that we've gone within a 10-year period from about a $400 million investment in research from the National Institute on Aging to over $3 billion a year of funding for Alzheimer's, which is fantastic. And when the NIA gives its medical research grants, now over $3 billion worth, they've always said, and we want X percent, I think it's 20% of the people in your research, in your clinical trials, to be from diverse populations. But they never had to enforce that, and so they never did. And so only a tiny percentage of the people in those research trials are actually people of color, rural, people who have been minoritized. So we have to start talking about it so that we're not playing this pretend game any longer, to be honest. And starting next year, there's actually a new mandate calling for clinical trial diversity that hopefully will be followed up. So the second piece of this is that in our field, a lot of the medical establishment and the research establishment doesn't really understand how to do that. Of course, if they understood how to reach this magic diverse population, they would do it. And unfortunately, our experience is that the field approaches it in a very transactional way. I will go into Walmart and I will give someone a $10 gift card if you will sign this registry, and we'll go into a Black community, we'll go into a Filipino community, and we'll get people to sign up for a registry because we gave them a $10 gift card. To a lot of the academic community, that sounds like it makes sense. To those of us on the ground, we think it's insane. Because what happens, how does that build any trust? How does that invest in the communities that are under-resourced, that don't have a Deborah Tan or a Dr. Ford educating them, bringing them health services, which is most of the country. So we are trying to get people talking about how to really create relationships and build trust. You said the main word was building trust. And the only way to really build trust with communities that haven't been resourced in this country really is to start by listening. Listening to what their experiences are, listening to what the community feels that they need, not coming in and saying, we're gonna do a focus group, here's the pencil and paper, and we'd like to ask you these questions. It just doesn't work that way. And that's what Dr. Tan has allowed BrightFocus to do. After she grilled me extensively on my motives, she's allowed BrightFocus to come to her community. And that's another story for another day, but I'll stop there.
Thank you. And I think that was actually a really good segue The next question that I have, and I'm going to give this question to both Dr. Ford and Dr. Tan, and I'm going to start with Dr. Ford. The two of you have been incredibly successful and effective in engaging community, building up the trust, building up participation. And one of the things we like to do in the museum world is do a slight differentiation between education and learning, right? Education can sometimes be an act. Right, I'm going to educate you about this. Now, some of us, I was that kid. I did not mind that perspective. But when we talk about learning, we talk about the ability to take it in, right? To take the education in and to perhaps use it or build on it or, dare I say, share it with the next person. So when it comes to community learning, a space where you two have been very effective, what has been your approach? What have you found to be necessary ingredients to make actual community learning work?
Thank you so much. That's a wonderful question. And I go back to Dr. Tan's point. We can't talk about any disease if the community doesn't know what it is. The way we approach community engagement at the Medical University of South Carolina Hollings Cancer Center is to form partnerships. We are the only National Cancer Institute designated cancer center in the state. Our catchment area is the entire state. We identify community partners and leaders in different counties in the state, and we meet with them. And we say, what is it that you are interested in? So it goes back to the listening. We start with what is important to them, and then we listen, and then we try to think about how we can build in some of the activities that we're interested in, like the screening. So we have a lot of different programs. We've touched 2 million people over the last 5 years, but a lot of that is through our partners. So if we have a program called SCAMEN. It's a prostate cancer education, learning about prostate cancer, and then we navigate the participants to prostate cancer screening with informed decision making for the next 3 months after the session. We start every session by thanking the Black men for being here, and we tell them, you are important.
Yes.
You are valuable. You are the backbone of our communities. We need you to be here, and that's why we're here today. Because Black men don't hear often enough how important they are. So once we say that, and then we enter into this partnership, then the men who are in the sessions, often they volunteer to host another session. And that's how we build the trust with the community. So that's how all of our programs go. We don't recruit to anything. We have community partners, they recruit, and we can bring a program, we can bring follow-up, we can bring navigation to treatment, but it's all about the true partnership. We have a grant with South Carolina State University, which is a historically Black university. This grant, when we were awarded the grant in 2017, it was $12.5 million. We didn't keep $10 million and give South Carolina State $2 million. We divided it equally between the two schools because we're partners. Every single part of that grant is co-led by investigators from our university and investigators from South Carolina State University. So a true partnership means we're sitting at the table together, we're designing the program, we're figuring out how to proceed. You saw our vaccination van, the mobile unit in the video. We started working with school nurses across South Carolina to bring this, we're vaccinating for the human papillomavirus. The schools and the state health department asked us if we would be willing to give to vaccinate for other childhood immunizations. And we said, yes, of course. Then that became a partnership because the schools were in desperate need of getting their students vaccinated, especially with the pandemic. A lot of kids were really in danger of getting letters letting them know that they could no longer come to school because they weren't up to date. So that, a partnership is give and take. We sit at the table together. The community members have ideas. They asked us, the first HPV clinic that we held was in Cherokee County, South Carolina, which had the lowest HPV vaccination rates in the state. That's why we chose Cherokee County. When we met with them, they said just what Dr. Tan said. A lot of people in our community don't know about HPV. So before you bring your mobile unit up here, how would you feel about having a town hall meeting? We said, great. They organized it. It's a virtual town hall meeting. They put the agenda together. So of course, if we put the agenda together as academicians, right, we're going to have all the experts speak first. And then if there's time at the end, you squeeze in a community person, but oh, I'm sorry, you were supposed to speak for 15 minutes. We only have 5 for you, Mrs. Smith. That is not how this agenda went. They put the agenda together. They said, we only want 30 minutes of talking. We want the other 30 minutes to hear from the parents and the students. In the 30 minutes of talking, the first speaker was Mrs. Cody. This is a video that's on YouTube. We share it with other school districts. She's a science teacher in Cherokee County School District. She shared her experience of being diagnosed with a high-risk HPV type before the vaccine was made available, and how stressful it's been and painful it has been for her. The next speaker, the one who really brought down the house, was her 14-year-old son, Cody, my brother CJ. So he talked about his rationale for getting vaccinated. And just, they say out of the mouth of babes, that his testimony and his decision-making process, and he said he didn't want to be the cause of his partner having to go through what his mom has gone through, and who wouldn't want to get the vaccine to prevent your partner from going through that? And he really brought down the house when he said he had just read The Immortal Life of Henrietta Lacks. A 14-year-old kid who read it on his own, picked it up. So engaging the community, there's more richness, there's trust. We have a better outcome than we could ever have. And clinical trials have to exist in partnership with the community. These trials are really important for the health care of community members. You take something like a medication for Alzheimer's treatment. As has been said tonight, if people of color didn't participate in the trial, we don't know how well that medication works in different population groups. When someone goes to the doctor and they need a medication for Alzheimer's, the doctor goes to the scientific literature and says, let me look up these studies that have been done on this particular medication. And the doctor will say, wow, 90% white sample, 90% white sample, study after study. But then they'll turn to the patient and say, it's the best we have for at this time. The doctor does not know how well it's going to work because we don't have the data. So when community members become partners in the entire research process, including clinical trials, then we will have true community engagement. We have to be part of the whole process. We have to be part of when the study is being designed, are there community members at the table to say, oh, this isn't going to work?
Right.
Why? Well, the National Cancer Institute has started doing that. The Department of Defense has been doing that for years with their trials. Every study done by the Department of Defense has community representatives at the table. Are these drug companies, pharmaceutical companies, do they have community people at the table when they design their trials? Or do the academic centers have community people at the table? We need community engagement from start to finish, just like we did with our HPV town hall meeting.
Thank you, Dr.
True
Ford.
community engagement. Thank
Yes. So I'm hearing a couple things, partnership, but I heard you also punctuated with true partnership several times, right? In terms of co-leading, I heard you use the word co-leading, let the community plan the agenda, because I also heard you use the word testimony. You don't have to have a culturally competent, trained staff if you are also co-leading, because that community will say, we're going to start with some testimony, and then you're going to sit there, and we're going to let the rest of the community tell you what we need. So I'm hearing partnership, authentic partnership, co-leading in that space and letting those voices guide you. But I also heard some authenticity. I know why we went to that community, because it was going to have some good outcomes if they could get them to participate. But then when you get there, the listening is what actually helps you get to those outcomes. So that strategy for community learning is really heavily based in partnership and co-leadership. Dr. Tan, your thoughts about your thoughts or your go-tos in activating community learning in the work that you do.
Yeah, Dr. Ford hit on a lot of key points, so I certainly won't be redundant with you. But I heard her in the very beginning, she spoke to validation when she was talking about Black men, but who doesn't want to be validated in the work that they do and whom they are? I also heard a little bit of access. Very key, very key. If I were to take a poll right now and if I were to ask you, what do you use to relieve a headache? Some of you will say Advil, some will say Tylenol, some will say, give me something else. Advil, Tylenol, what else out there? What do you take? Excedrin, one more.
Cannabis.
Cannabis, that's a good one.
Not me, of course.
Of course not. Thank you. We hear all of these things, but again, that is why it's so important that we are part of clinical trials, because what works for you may not work for you. So we have to be at the table as it relates to clinical trial. But we have to be educated on what that is, because we've already spoke to the distrust already. And hearing about Henrietta Lacks, oh, it's like music to my ears. Yes, yes, yes. So again, what worked for me in my community is the fact that I've been in the community for such a long period of time. And so my name precedes me, in that not because I'm all of that in a bag of chips. No, no, no. It's because I've worked hard in my community to have name recognition. And also people know that I care. You see, you don't have to tell me you care. I can feel that when I'm in your presence. That's a vibe that one picks up. And so I have compassion. And so I'm able to do the work because people trust me. And they trust me because I've been in the community as an activist. You see, I just didn't come out a couple of years ago and begin my activism work. I've always been active in my community. So validation, access, those are key, and certainly education and training.
Thank you for that. Yes. So there I heard validation of those you are trying to help, giving them their own sense of value, acknowledging that you see that. I also heard reputation precedes you, right? So the reputation of who's coming into the community makes a very big difference. Can also partner with partnership, because sometimes you can open the door, but you can't convince folks to walk through it. So you're going to need someone who perhaps has that reputation, has longevity in the community in order to be able to do that. And sometimes the folks who are coming maybe have had a reputation that does not inspire trust, and that is another reason for partnership and also for growth. And I think that leads me to a question that I would like to present to everyone who is here. And I want us to talk about our favorite barriers to getting this done. And what we're talking about is, we're talking about getting more diverse groups, African Americans particularly, engaged in clinical trials. We're talking about moving forward the research towards the cure for Alzheimer's. We're talking about community health and education in those space. There are many, many barriers, and from each of your perspectives, I'd like for you to pick one barrier. That barrier could be the thorn in your side. It could be the barrier you have learned to work around, or it could be the one you're still trying to figure out. And then share what your thoughts and your strategies are around getting around that barrier. Just, we don't have to fix it, but I'm just curious in terms of what we're working with. And I think I will actually start with sharing the first barrier, because it's been mentioned a couple times. Some folks in the room know that my background is actually in biomedical engineering. That's actually what I studied and what I researched. And one of the interesting things is I worked with HeLa cells in my work. Right, so these were the I love the fact that now everybody knows what I'm talking about. It's sort of in the Henrietta Lacks. If you're in this space, if you're in the biomedical space, if you're in a lab, if you're doing any of this, you are working with these cells. They are ubiquitous. They are everywhere. No one ever said to me that someone who looked like me had contributed that, who was a major part of our science. What folks did say to me is that they were experimenting on black folk in the basement. Now, these are real stories about sort of what was happening. And so my barrier is diversity in the lab space. And for young scientists of color to be able to not just recognize and see their future selves, but to also see their past selves in that space, right? Because there is something about being a trailblazer, but there's also something empowering about being part of a legacy and sort of carrying and moving things on. And so I think for me, one of the barriers we're still trying to work through is retaining brilliant minds of color, African American minds in particular, in the lab space, sort of through the long haul. And I think that one of the strategies will be helping us see ourselves in that space, not just in the future and the present, but also in the past. So that is my barrier and what I think about in terms of solving that. Nancy, what is a barrier that you are working with and through?
Well, I'm glad you brought that up, and I just want to mention that BrightFocus is very focused on emerging scientists coming into the field and trying to encourage diversity, global diversity, because we're a global foundation. We fund scientific research all over the world. And so as an example of one of the things that we do is we provide travel grants to young researchers of various colors and from different types of communities and backgrounds to go to scientific conferences, again, to try to keep people in the field, since our area are those research conferences. There's so many barriers, but I'm going to, I'll talk about one that I learned from Deborah and her community. I think one of the greatest barriers is something I only learned about during this past year from your community, and that is mental shackles, which is a term I never heard before. And is that a term everyone here has heard?
I think it works to get us all on the same page. So give us the definition that you're working with.
I don't have a definition, but no, when Deborah and I started working together, I was talking about the research community, the academic community, and sort of where they were mentally shackled. I didn't use those terms, but right, we'll go in and we will educate them and we will get them to do this, and we will. So to my mind, that's a mental shackle. That's a way of looking at something that a lot of people can't change. And Deborah was describing, Dr. Tam was describing her community, and she said that this tremendous frustration because people have been treated in a certain way for so long that they no longer even necessarily try to improve their situation and advocate for themselves because they have these mental shackles that let's just keep things the way they are. I'm okay right now. But going into her community and learning that somebody whose wife was diagnosed with Alzheimer's, the doctor said, your wife has Alzheimer's, and sent him home. And we would say, did he give you a prescription? No, well, number one, he didn't want to go back and ask because he can't afford the copay. And number two, he's not sure he could afford the prescription if there was a prescription. And so, I mean, that's an economic shackle, but it's when that happens enough times in a community, you don't try anymore. And I don't know if I described that correctly.
I like how you described that. Thank you. Yeah.
So,
but I think it's on both sides, very much so, both sides.
So, Dr. Tan, since you were a part of that story, what would be a barrier that you're looking at and thinking of how to power through?
Okay.
First, I think it's important that I qualify and say this. When I think about barriers, I think about opportunities. So I don't spend a lot of time there because I typically will seize a moment. But I will say this as it relates to barriers. No one, and I repeat, no one should be denied the possibility to be healthy for belonging to a group that historically, and we are certainly in the right place at a museum, historically has been economically and socially disadvantaged. That could be a barrier that I want all of us to just kind of marinate with right now. No one.
Thank you for that. And I like that approach of, I don't see barriers. I immediately flip to opportunities. It reminds me of that saying, a failure is only a failure if there's not a try that happens after it. In thinking through those ways. So thank you for those two really good examples of the types of barriers that are in this work. One is mindset, right? And not incidentally mindset. Some can be because this is the way you were trained. These are the experiences that you've had on both sides of that. And one is also abject continuum of systematic being in these places, right? And in terms of thinking through that. So as I come to this side of the room, I'm going to come to a different perspective, perhaps. So Stacy, of course, you sit in a very interesting position at the top of a foundation who has decided to cure Alzheimer's disease at some point. And so when you think of barriers, what do you think about the barriers that you're looking at and are working through?
So I share a little bit about Dr. Tan's view of barriers, but usually a barrier has some kind of fear associated with it. And the power of somebody identifying a barrier to me is the first step to opportunity, but it's also having to listen to understand why the barrier exists and why it's perceived as a barrier. And when it comes to healthcare and what we're talking about in terms of health equity, beginning in the lab, beginning with the people who are doing the research, beginning with an understanding that we have the power and the potential of precision medicine in our lifetime, then you immediately get to the point that in order to have that, you need to have everybody at the table, men, women, all cultures, all races, in order to really speed it up and make sure when these breakthroughs, these medical miracles happen, everyone can benefit from it. So I refuse to go there with the barrier and to figure out how we turn that around into a win. But this is one of the great places where people can come together because there are no economic or social barriers to getting the diseases. So we all need to be part of solving for the diseases.
Yes.
Thank you for that. All right, Dr. Ford, when you think of barriers, or apparently not of barriers, I am all about that life. In terms of thinking through that, so what are you working with and thinking through in terms of those strategies?
Thank you. My mind always, when we talk about clinical trials, I go back to 1996 or 1997 when I was invited to participate in the first biomedical ethics conference at what was Tuskegee Institute at that time. And it was in partnership with the National Cancer Institute, Tuskegee. And so we were there for 3 days, presenting on National Cancer Institute funded research, and some of the survivors of the Tuskegee syphilis study were there. By the way, some people say we should call it the U.S. Public Health Service syphilis study and not the Tuskegee syphilis study because they're the ones who sponsored it. But The survivors were there, and then their attorney, Mr. Fred Gray, was also there with them. So we had a chance to meet them, to thank them, and we thought we were like really on the right track. So this conference went on for 3 days, and on the third day, Mr. Fred Gray said, may I say something? And the organizer said, of course. And he said, he called the survivors of the study the men. And he said, the men have asked me to say something on their behalf. And he said, we have been sitting here for 3 days listening to speaker after speaker talk about how few people of color there are on these trials. And he said, quite frankly, I have to tell you, the men are appalled. He said the men cannot believe that after everything they went through, which means that we now have the informed consent process, we have informed consent forums, we have data and safety monitoring committees, we have institutional or human rights review boards for every study. He said they're proud of the fact that because of what they went through, all of these safeguards are in place to keep this from happening again. And he said, if people of color don't participate in trials, we're doing the men a disservice because they feel as if what they went through is in vain. And that completely turned my perception of clinical trials and participation. So now every time we go out to the community, we have a program called Moving Up, Train the Trainer, where we leave everything we know about trials and about cancer education, just prevention. We leave it in the community on memory sticks and binders, and the community members then lead sessions with other community members. But one of the modules is a clinical trials module, and so I rewrote it. So we focus on the atrocity. We talk about the atrocities. We acknowledge there have been terrible things that have happened. That's true. But we focus on what has happened since the U.S. Public Health Service syphilis study, all of the safeguards that are in place. And I share the story about the men who were in the study and how they want us, because the men said, you know, we're going to miss out on these scientific breakthroughs if we're not at the table, if we're not in the trials. So, thank you.
Absolutely.
Thank you for that. That is an amazing way of telling that story. And again, I'll echo what Dr. Tan said. What an amazing place to be having this conversation, because I think the way that we tell stories and the way we give credit and the way we talk about this history matters in terms of that. And it's also how people will relate. Some folks will come into this because of the science, some will come in because of the cure, some will come in because of the legacy. I think that's really important. We are almost coming to the end of the session. I've got a couple of more questions here. I am going to take one or two questions from the audience. That would be questions, not statements. So the question that the last formal question I want to sort of close out with here, it was something that Nancy had alluded to. For quite some time, there has actually been written language requiring diversity in clinical trials. You know, 20%, 50%, 10%. But of course, you can also check the good faith effort box on that, especially when there is no double checking for accountability. Recent updates to the language add a little bit more accountability to it, but I'm still going to ask the question, right? Instead of just leaning in, it's there, we have the language we can use. So my question to each of the panelists, in a very few short words, from your own perspective and experience, what would it take to make that requirement not become another hollow promise? Right, so what would it take? Let's say the number is 20%. As you heard in the video earlier, the African American participation is far less than that, closer to 4.5% on a good study. And so it's very, very low, right? It's very, very low. And again, if we understand treating community is treating the population, and our country is growing and diversifying every day, right? So at the end of the day, not having significant portions of the population involved in these tests means that our medicines, let's say that the medicines are only as good as the percentage that they represent, right? All right, so we've got this mandate, we've got money, we've got funding, we've got folks who are actually going to try to get this done. From each of your perspectives, what is sort of one thing that you could do or would champion be done to help move this from on paper mandate and out of the hollow promise space? Like, what can we do to get this done? All right. Really long question. It's deep. You could possibly save the world with your answer. Who would like to share first? Good. I see Stacy reaching for the microphone.
It's a tough question. But when I think about what you're asking, I always start with knowledge and the conversation that we're having today. I think flipping the mindset collectively about health equity begins in the lab, and to think about this as a continuum of all of us to be involved with the stories and the experiences that we've heard about today needs to just, is a way to bypass many of the pain and the grief and the hurt into the opportunity for everybody to understand they're part of the community, to get us to precision medicine, and we get there with everybody. So flipping that mindset about health equity begins in the lab and it needs all of us, something like that is probably, from my perspective, what needs to be said and pushed out more. It's just, and we've done it. We've done it with the fried eggs, we've done it with the cars that used to get action, we've done it with AIDS, we've done it with cancer. We can do it with this because as we age, we're going to get something. It's just a question of what. So everybody has it, you know. Every brain is at risk, every brain. So I just think starting to build the conversation that way and trying to make it a little fresher in the way we think about it, because that's where the science is. And the scientists know this. So this is just about getting the community and the public more engaged. So that's the one word, you know. What am I going to do?
Thank you. Thank you. Let's bounce to this side of the room. Oh, I see a finger point there.
When Dr. Tan points a finger at you, you go. I'm going to say, Tuskegee and other atrocities aside, there are a lot of people now who will say the greatest barrier is that people don't know about clinical trials. It never comes into their orbit. So I'm going to say, go to the movies, who's watched Grey's Anatomy, or Still Alice, or This Is Us, or Glenn Campbell, I'll Be Me, or The Father, and I was involved in the movie Glenn Campbell, I'll Be Me, which was a documentary that came out in 2014. And one of the pharmaceutical companies paid to get it on CNN. The first night it showed on CNN on June 29th, 2015, it had 5.7 million viewers. And it was about an octogenarian with Alzheimer's. Happened to be a big country music star, but I think that we have to use popular media and fun entertainers and make it not so grim, and then bring those programs everywhere and start to destigmatize the conversations so that you can tell. And then you have to make a place where people can go to participate in research, which is not in most communities.
Thank you for that. Bring the information to where people are in a form in which they can take it in.
Yes.
All right, bring on the comedians. All right, Dr. Tan, Dr. Ford. Ooh, Dr. Tan has hands on my phone.
I love her. You know, that is a really potent question, and it really makes all of us think. And I'm just going to surmise that if you're within the sound of my voice, you care. So I also believe this adage, we reach one and we teach one. So wherever I am, I do my best to illuminate information in the space. And so I simply have to ask each and every one of you to do the same. That we advocate for those who cannot. And so I can't be where you are. I can only be where I am. And so I represent there. But I believe if we collectively do that, exponentially, it's reaching more and more people. So I ask of you on this afternoon to not shy away from the subject matter, to be powerful and to be bold, if you will, and just share with compassion where a resource may be in your community. And that just makes me feel forever confident that we can, through each and every one of us, touch lives, influence lives. And that's kind of my vision. That's what I see as I sit before you this afternoon. Yeah.
Thank you for that. Thank you. So we have start at the beginning, start in the lab. Don't forget the basic research. And we have meet the people where they are, in the language that they can hear you. Then we also have everyday people as ambassadors, just having conversations, sharing the words, say what you heard. I was at the museum the other day. What y'all do over there? Oh, God, we talk about Alzheimer's. Boom. There you go. Okay. And so we have those. So Dr. Ford, what are you adding to this basket of amazing tools of solutions?
So much has been said already. The number one reason people participate in a trial is because their doctor asked them to. So I think we really need to work with physicians to help them to understand, to not just offer trials to some patients and not others, or not make assumptions that some people will or will not participate in a trial, or will or will not be interested. And sometimes that requires giving incentives to the physicians, giving them travel money or giving them discretionary funds. Sometimes we have to incentivize them because it does take a little bit more time to try to talk to a patient about a trial. But starting with the physicians, because they're number one, that's the number one reason people join a trial. The other thing is access. I mean, these trials are done at centers usually with specialty care. Yeah. So if you're living in a rural place, you may not have access, but with telehealth, you can, right? So I think building on our technological resources that we have, and trying to expand telehealth so that we can offer trials to people who live maybe in more rural places that may not have a neurologist or a neuroscientist, but they can connect them virtually at that site with the person who's doing the trial. If they need blood draws, those could be done at the site. If they need an MRI, they have to go to a place where there's an MRI, but there's a lot that could be done right there. They wouldn't have to travel. It's closer to home. So those are just some things. Thank you.
Thank you for that. And I like the surprise one. Start with the doctor. And so I think that's why we have these conversations, to really unearth where the challenges are, because start with the doctor, and I heard a lot of good insight around some biases, explicit or implicit, around who we recommend. But I also remember from the snippet that we saw about not all doctors are trained in Alzheimer's, and how to recognize it or see it to offer folks. So make no assumptions that no one in this web that we're weaving needs help. And of course, access. And thinking creatively about some tools we already have to expand that access. All right, so who out there is going to venture their 15 minutes of fame to secure a disease by asking a question? I am eliminating all BrightFocus board members. Thank you, says our third-year pharmacy candidate.
You should take that one.
Okay, so thoughts on that as someone who made it through. So one, I think that we take our definition of community and get serious about it. Usually when we're talking about community, we're talking about those who we are going to serve, not those who we are preparing to serve. And understanding that if you are one and only, 2 of 200, to make some intentional effort about providing resources for candidates of color to get together. Very similar to providing money for travel funds, et cetera, et cetera. Your peer may be across 2-3 campuses in a state line. So thinking about what that means. I think the other thing is the way that we allow access and opportunity to attend and present at conferences, as well as the position that we get to be on the authorship of papers, right? So part of that is getting folks out there, but also part of that is reinforcing the sense of value that they are bringing, that you are bringing to the field and the spaces and places that we do. And last but not least, I think it's also understanding the network. One of the wonderful things about being American is that we live on our own independent way of moving forward. But the interesting thing about that is that's not how it works. And so I think part of engaging young scientists in the network while they were still in training so that they understand that when we come out, that is how the greatest science happens. It tends to be partnerships that are actually happening in that space. And so I think that that's also really important. And the second thing, and I will say this from a sort of a personal perspective, sometimes many of us are motivated by wanting to serve the communities that we come from and wanting to continue those legacies. So incorporating explicitly the impact on communities where our students are coming from is something I don't think we do enough of. So yay, doctor. All right, that was a great question, great modeling of how to ask a question too. So is there one more question from All right, so I'm going to do something different. Oh, I'm not supposed to step in front of the camera. We are going to sort of close out, and there's one question coming. I'm going to introduce you to the way that the International African American Museum begins each day. So each day before our audience and our visitors come, everyone who's in the building gathers. We gather at our front entrance. We are the International African American Museum, and our acronym is pronounced IAAM. And so we stand in a circle, and each of us has the opportunity to say, I am. And then we put in the word. We don't get to say I'm, because that's not our acronym. So we say I am, and we put in the word with no explanation, no justification, no courage needed, no judgment, no anything like that. And so we simply say I am and feel in that way. And so what I would like to have, we're going to sort of kick this off from the audience, and then we're going to bring it around to our panelists and let them have the closing statements. And I'm going to allow our panelists to break the rules. As they say their I am one word, they'll get to explain in a few words why they feel that way. But audience members, you do not. You just get the one word. And so I would like for 5 folks to stand on up, just stand, just come on, just stand. 1, 2, 3, yep, 4, 5, 4, 5. Okay, that's 5. Gentlemen.
Yeah, exactly.
Gentlemen.
Gentlemen.
I would like for the Zoom audience that cannot fully see what is happening.
There we go.
So the women are leading. And so Brandon is going to hand the mic around, and folks, just give us the word that embodies how you're feeling right now as we're closing out our session.
I am blessed. I am encouraged. I am refueled.
I am smarter.
Ooh, love that.
Yes. Oh, wait, we have one more.
I am determined.
I know that's right. Thank you.
I am very jet lagged. And I am grateful. I am so grateful to be a part of this. And I am mostly grateful for my sister, Deborah Tan, who's allowed me to engage in this work.
Dr. Tan.
I am intentional. I work with all intentionality. I am accused of being stoic and serious, and that's probably true. But I have all intentionality of being effective.
Thank you. Dr. Ford.
Thank you. I am hopeful because there's so much energy talking about clinical trial diversity. Hopeful, I'm optimistic, and I will tell you that at the Medical University of South Carolina, Hollings Cancer Center, 30% of the treatment trial participants are people of color. So.
Yeah, wow, the work is paying off.
That's awesome.
I am inspired. I'm thrilled to have experienced the museum today and to have the history brought forth in such a powerful way that the museum has allowed. And I'm inspired by the level of conversation and interest that has happened today, that this is the pebble that will be tossed in the water. And thank you all for that.
Thank you for our panelists. And I will say in closing, I am grateful. I am grateful for the team here at the International African American Museum that does not doubt their CEO when she says, I want to panel on Alzheimer's. And here's the people you've got to. In terms of that, this is a bold and creative team. I am grateful that people showed up. It is a Friday night in one of the most vibrant cities in the world. And folks are here to have this conversation with us in this very unusual space. And I'm so grateful for that, for folks coming. I'm grateful for the genius that we got to listen to today, because hearing these folks speak with their passion and their knowledge and their work, I am grateful in advance for the work to come. And so that concludes our program for this evening. Thank you all for attending our presentation of Small Miracles, brought to you by the International African American Museum and BrightFocus Foundation. Good night.